Hello, everyone. Good afternoon, and thank you for joining CDTRP's Level Up Research Connect series. My name is Elaine Yong. I'm a CDTRP PFD partner and also the PFD co-lead for Theme 4. I will be facilitating today's webinar. Also, just to give you a little bit more background about myself, I'm also the mother of a pediatric transplant recipient, heart transplant recipient. Addison will be celebrating her 12th heart anniversary this April. We're actually going to be celebrating by going to the World Transplant Games in Perth. This will be her 4th competition. So like many of you here who are connected to the world of transplant, either as a patient or a patient partner or a care provider, COVID obviously has been a huge impact in our lives. I think it's been it's one of these moments where we always talk about how when we're all older and we look back, we've lived through some incredible history, and I think the impact on the transplant community has been pretty severe. I can speak from my own experience on that. So I'm really looking forward to today's discussion. So this is our first webinar for 2023. Welcome. Unlike previous webinars, this series streamlines our previous theme, hub, and working group webinars. And the goal of the CDTRP Research Connect series is to make it easy for our members to know about and attend high quality presentations across all themes and topics of interest. And I see from the number of people who are joining us today that this one is obviously, as I mentioned, going to be highly interesting to our community. So each of these webinars will be hosted on Tuesdays. You can visit cdtrp.ca to view the speakers and register for the subsequent webinars. So before I introduce our speakers today, of course, I'd like to start with a land acknowledgement. The University of Alberta hosts CDTRP, and we respectfully acknowledge that we are located on Treaty 6 territory and respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all the First Peoples of Canada, whose presence continues to enrich our vibrant community. I'd like to acknowledge that I am personally coming to you today from the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh, otherwise known as Vancouver. I am extremely grateful to be a settler on these lands and really want to acknowledge the huge presence that being in these beautiful lands during COVID really played on all of our, I can speak for my family, our mental health, and being able to go out and enjoy beautiful surroundings, the land that the First Peoples have taken care of over, centuries was really, I think, the only way we got through the pandemic without more serious mental health issues. So I'd also like to encourage all of you, I know you're attending from all over the place, please, if you'd like, you can acknowledge where you're coming from, your lands, in the chat, in the group chat. It's always so great to see all of the different various lands that we are coming from for these events. So a few housekeeping notes. Today's webinar and discussion are being recorded and will be posted on the CDTRP website and YouTube channel. During the presentation, we kindly request you turn off your cameras and your mics. And once the presentation is complete, you can turn your cameras on if you'd like. If you have a question or comment, you can ask the presenters directly. If you don't want to go public with your question, you can send me a private message. And I will ask on your behalf without sharing your name. So just whatever works for you. We definitely want to get some time for questions because I'm sure there'll be a lot of them. All right, so let me start now by introducing our speakers today. Dr. Sara Belga is a clinical assistant professor at the University of British Columbia. She received her medical degree from the University of Lisbon and completed her training in infectious disease at the University of Alberta, followed by a one-year fellowship in transplant infectious disease at the same institution. Additionally, she rotated through the Immunocompromised Host Infectious Diseases Service at Stanford Hospital and Transplant and Oncology Infectious Disease Service at the Brigham and Women's Hospital and Dana-Farber Cancer Institute. She joined the Transplant Infectious Disease Program for BC in 2019. Her clinical responsibilities include the care of pre- and post-transplant patients at Vancouver General Hospital, Her research interests include latent viral infections in transplantation and immune monitoring strategies in transplantation that allow personalized medicine and individualized approaches to care. Her other interests include epidemiology, biostatistics, clinical trials, and drug safety. Our other speaker today, Dr. Catherine Burton, is an assistant professor at the University of Alberta. Dr. Burton's primary areas of research is in immunizations and vaccine-preventable diseases in children, especially immunocompromised children who often require alternate vaccine schedules and or vaccine dosing to ensure optimal protection. Much of her immunization-related research is in collaboration with national networks, including the Special Immunization Clinic Network and the Canadian Donation and Transplantation Research Program, with current studies looking at the use of live varicella vaccine in children who have solid organ transplants, and evaluating the immunogenicity and safety of COVID-19 vaccines in children who have had organ transplants. And Catherine and I have had the pleasure of working together on those projects. Thank you to this fantastic group of speakers for joining us today on this really important topic that I know I can see just again by the number of people who are joining us today. Definitely an issue that resonates with the transplant community. So I'll pass it on to you two to get us started.
Everyone, and thank you, Elaine, for the kind introduction. So it's a pleasure to be here to talk to you about COVID-19 therapeutics for transplant recipients. These are my disclosures. And the objectives of today's talk is to provide you with an overview of COVID-19 therapeutics for solid organ transplant recipients. And from now on, I'll refer to solid organ transplant recipients as SOT. We're going to talk about how research contributes to the implementation of therapeutics for adult and pediatric SOT recipients. And we'll also go through the current knowledge gaps in research and next steps. So as you all know, at the end of 2019, a novel coronavirus called SARS-CoV-2 emerged and rapidly spread throughout the world, with the first cases of pneumonia, respiratory failure, and death reported in China. Although we use COVID-19 and SARS-CoV-2 interchangeably, COVID-19 refers to the illness caused by the virus. And as if everyone remembers very well, a COVID-19 pandemic was declared in March 11, 2020. However, since then, the virus has changed significantly, and I'm just providing here a timeline of some of the COVID-19 variants of concern from Alpha to Delta and now Omicron, with Omicron having evolved to include many different sublineages. And what are the COVID-19 stages of disease? So I won't get into a lot of details, but just to tell you, usually the different stages which will be relevant for the talk today. So people get exposure to SARS-CoV-2. Not everybody will develop symptoms or get infected, but those, I'm sorry, the slides are advancing too fast, and I apologize for that. Anyway. I think I don't know that I can fix it. I tried to fix it before, but anyway, so I apologize for that. Anyhow, back to the slide, we have a period, incubation period before symptoms develop, and then once symptoms develop, that's usually the time where the viral load reaches a peak and then starts coming down at around day 5. But of course, this is for immunocompetent patients. It may be a bit different for immunocompromised hosts. But we're going to focus on mild to moderate illness, which usually doesn't require hospitalization, as patients usually have good oxygen levels. But we'll focus on antiviral therapy at this stage to prevent progression to severe illness. This is just a slide showing what prevention and treatment strategies we have for all patients, and everybody knows very well about prevention of infection. Of course, vaccines being extremely important, but we're going to be focusing mostly on early treatment. So in yellow here, we'll talk about antivirals and monoclonal antibodies. We'll talk a little bit about some monoclonal antibody for prevention, but essentially we'll focus on these strategies to prevent progression to severe infection. Okay. So what has the impact of COVID-19 been in SOT recipients? One of the earliest reports came from the University of Washington in Seattle, where early in 2020, they reported a mortality rate of around 20%. Later in that year, they reported a mortality rate of about 13.7%. And it was very clear, not only in this report, but other reports, that the mortality appeared to be higher in lung transplant recipients when compared to other SOT recipients, adjusting for multiple other factors. However, in all SOT, major risk factors for mortality were pretty similar to the general population, and these included age above 65, heart failure, obesity, chronic lung disease, among others. I especially like this paper and really like how they summarized some of the impact and the challenges of COVID-19 on SOT recipients. So similar to what I said, the mortality in the first wave was quite high, up to 25% in certain parts of the world, but decreased to 15% in the later part of the year. During that first year, we had evidence to support the use of steroids in patients that were admitted with severe COVID. And during that year, there was a 15% global reduction in transplantation. In 2021, we had vaccines, and the crude mortality decreased to 8 to 10%, but of course, depending on vaccination status. And then there was evidence to support the use of other treatments, including immunomodulators, antivirals, such as monoclonal antibodies. And there was evidence that despite reduced immunological responses to vaccination, they were still protective against death. So in 2022, started with Omicron, which was highly infectious and certainly impacted transplant patients quite significantly. And at that time, there was a need to determine the optimal vaccination schedule, but it became apparent that the third dose, or I guess the primary vaccination series that increased the third dose, did protect against both death and hospitalization. And the focus was really on applying significant efforts to sustain transplant throughout all COVID-19 waves. Okay, now on to COVID-19 antivirals. What is an antiviral? So an antiviral is a prescription medicine that fights against viruses. And I just put here some examples of viruses for which there are antivirals. So for example, flu, HIV, hepatitis, CMV, which is well known to a lot of you, as well as other viruses such as the chickenpox or shingles virus. It can be given in multiple ways. So as a pill, liquid, most often in children, intravenous, intramuscular injection, or as an inhaled powder. For COVID-19 specifically, antivirals are either given as a pill or intravenous, intramuscular. It's important to note that the highest benefit of antivirals is if these are given early into the illness to prevent the virus from further multiplying and causing severe pneumonia. And what antivirals have had proven benefit? This is by no means a complete list, but this is what we're going to focus on given the data that we have and what we have available for SOT recipients. So remdesivir, we'll talk about nirmatrelvir and ritonavir, also known as Paxlovid, and monoclonal antibodies. So in this slide, I just wanted to show you a bit of a timeline of the approvals in Canada. So we started off with remdesivir, which was approved in October 2020, initially for severe COVID and later for mild COVID to prevent progression to severe disease. And then we've had multiple monoclonal antibodies, which are listed here, and we're going to focus on the ones highlighted in bold. And then Paxlovid came along approximately a year ago, and that it's important to note that all except Paxlovid have been approved for individuals 12 years or older, weighing at least 40 kilos, and Paxlovid is only approved for adults at the moment. Okay, so on to remdesivir. This antiviral was originally developed for the treatment of Ebola virus disease following the Ebola outbreak in 2014-2016 in West Africa, but it had known activity against coronaviruses and thus was repurposed to inhibit viral replication by binding to a key enzyme called RNA-dependent RNA polymerase that is responsible for that. So it is given as an intravenous infusion once daily, and the duration is going to depend on the indication, but for the purpose of this talk, we're going to talk about the 3-day infusion for mild COVID. And I can't talk about this without giving you information about the landmark trial, which was called Pine Tree Trial, was conducted between September 2020 to April 2021, where remdesivir was given for 3 days for patients that had mild COVID and were within 7 days of symptom onset. And what they found was that this decreased the rates of COVID-19 hospitalization or death by 87% among those that were unvaccinated and were at high risk for COVID. Of note, only about 4% were immunocompromised. The important thing to know about remdesivir is that it requires 3 consecutive visits to an infusion center, and the doses are listed there for your reference on the presumption of a normal kidney function. This medication is generally well tolerated with no drug-to-drug interactions with anti-rejection medications. And what is the data in SOT? So mostly has been observational studies. I wanted to tell you about this study because it's a Canadian study from the University Health Network in Toronto, where they enrolled 192 adult SOT recipients from kidney, liver, lung, heart, and combined transplant recipients that had mild COVID. And this was during the BA2 wave in Toronto, so from April to May 2022. And approximately 45% received remdesivir, and 90.1% were triple vaccinated, meaning they got the primary vaccination series. And the outcomes are here, very evident in this Kaplan-Meier graph, where remdesivir reduced the risk of hospitalization by 88%, with an adjusted number needed to treat to prevent one admission of 15.2 patients. And so remdesivir appeared to significantly reduce the risk of COVID-19 hospitalization in a predominantly vaccinated SOT population. Now, on to nirmatrelvir and ritonavir, best known as Paxlovid. And so just to understand a bit about this antiviral, nirmatrelvir is a newly developed antiviral that blocks an important enzyme called protease of SARS-CoV-2, which is also key for viral replication. And the ritonavir component is used to slow the nirmatrelvir metabolism. The main advantage of this medication is that it's given as twice daily for a total of 5 days, and the doses that I've listed here are on the presumption of normal kidney function. And so one of the landmark trials that led to its approval, it's called EPIC-HR trial, that was conducted between July to December 2021, where nirmatrelvir plus ritonavir versus placebo resulted in a risk difference of almost 6% for COVID-19 related hospitalization or death among unvaccinated adults at risk for severe COVID-19. The most frequently reported adverse events were metallic taste and diarrhea. But the main limitation of this drug is really drug-to-drug interactions, particularly with calcineurin inhibitors such as tacrolimus and cyclosporin. Unfortunately, there's not a lot of data in SOT for that reason, but I wanted to tell you about one study that came out of Columbia University in the United States. In fact, they published a protocol early into the Paxlovid's approval, indicating an approach to manage Paxlovid in transplant patients, where they would hold tacrolimus after starting this drug, or reduce the cyclosporin dose by 80% during those 5 days that the patients were on the treatment. And then by day 6 and 7, they would check the levels to see if they were on target, above target, or below target. And based on that, they would kind of decide what the next steps were. Later on, they reported their experience. Again, this is a very small study, so it's a case series that included mostly heart, lung, and kidney transplant recipients, with a few liver transplant recipients that had received, for the most part, 3 doses of COVID-19 vaccines. They were within 3 days of symptom onset, and most of them were on tacrolimus. They reported that 8% were hospitalized, but they saw no acute rejection within the first month, and that after starting tacrolimus, 4 patients had above target tacrolimus trough levels, but only 1 patient ended up having an acute kidney injury due to an above target TAC level. And so they proposed that nirmatrelvir and ritonavir interactions with immunosuppressed agents can be reasonably managed with a standardized dosing protocol. They would, of course, include a transplant pharmacist. Okay, now on to monoclonal antibodies, which from now on I'll call mAbs. And it's important to understand a bit about how antibodies are produced before I talk about the mAbs. And so B lymphocytes or cells or B cells are the key antibody producing factories. Monoclonal means that it comes from a single B cell clone and recognizes and attaches to a single and unique part of the antigen. And it can attach to immune cells, cancer cells, or pathogens like viruses. The first licensed mAb was back in the 80s and was leronlimab against CD3, which is a T cell marker, so it was used as anti-rejection. And the first approved mAb to combat an infectious disease was palivizumab, which treats against RSV, which is a known cause of severe respiratory disease in the newborn and other vulnerable populations. These mAbs can be single, so with just one antibody, or combined, also known as cocktails, and that's used as an attempt to decrease the resistance against these agents. Okay, so how do these mAbs work? So I'll tell you a bit about the virus itself so that we can understand this a bit better. So the spike protein in the SARS-CoV virus allows entry into the host cells by binding to a receptor in the host cells called ACE2, which is here in blue. And this occurs through the receptor binding domain, which is in darker green here, with the S protein in the middle. All approved COVID-19 mAbs are considered neutralizing. And what does neutralizing mean? It means that mAbs block the entry of SARS-CoV-2 into a cell, making the virus unable to infect other cells and further multiply in the human host. Okay, so now we'll talk about not the first one approved in Canada, but just because we didn't have time for all of them. This one is called casirivimab and indevimab, which is administered as a single intravenous infusion, was previously approved for mild COVID-19 within 10 days of symptom onset, as well as post-exposure prophylaxis, so after someone gets exposed to the virus to prevent disease. And one of the landmark trials that was conducted between September 2020 and January 2021 was REGEN-COV, which was shown to reduce the risk of COVID-19 related hospitalization or death from any cause in high-risk patients. But unfortunately, as Omicron came along, there was reduced activity against the variants that were circulating, and so this stopped being used then. So what is the evidence in SOT? So there were, again, observational studies. The first one was a small study from the USA that included 25 adult SOT patients, mostly were kidney transplant recipients with mild to moderate COVID, and none had symptom progression or required hospitalization. But of course, this is limited. There was no control group. And then there was a larger study from France conducted between August to September 2021, where they selected SOT recipients that had non or weak response to 3 doses of the Pfizer vaccine. And to 182 of them, they give it as pre-exposure prophylaxis and follow the patients for 60 days. In darker blue here, they just showed what the baseline antibody levels were to the spike protein, and then how that changed with the mAb administration. They gave it monthly during those 2 months. And that they saw that the COVID incidence at follow-up was 0% in the mAb group versus 4.4% in the control group. And they proposed that this could be efficient in preventing COVID to counter viral variants such as Omicron. But of course, we learned later that it unfortunately didn't work anymore. Okay, so on to the next mAb called sotrovimab, which is given as a single infusion of 500 milligrams within 7 days of symptom onset. Sotrovimab is a bit different from other mAbs as it targets a highly conserved region in the SARS-CoV spike protein, so it's thought to be a bit more resistant to resistance. And one of the landmark trials that led to its approval is the COMET-ICE trial conducted between August 2020 to April 2021. And it showed that it decreased risk of all-cause hospitalization or death related to COVID, but this didn't include any transplantations. However, there was evidence of increased resistance to the Omicron BA.2 subvariant, and as of April 5th, 2022, was no longer authorized by the FDA. Now, just wanted to show you some real-world data that came out more recently, but it's important to note that this paper has not been peer-reviewed yet, but it's a large study from the UK, which is from the UK Renal Registry between December 2021 and August 2022, where they included patients on dialysis and post-kidney transplant, and they found a substantially lower risk of 28-day COVID-related hospitalization death compared to a medication that I didn't talk about, which is called molnupiravir, but hasn't really shown to be effective or very effective to prevent progression of disease. Of course, we need more robust data to corroborate this, and there are some ongoing clinical trials. And of course, more data is required on the current emergent variants, such as XBB.1.5. So I just wanted to show you this study again from UHN and observational that included 295 SOT recipients with mild to moderate COVID, enrolled patients between December 2021 to January 2022. They were within 7 days of a positive test, and mostly were kidney, lung, and liver transplant recipients. And 65% had the primary vaccine series, and 36.3% of these received sotrovimab. The study showed that there was a decreased risk of needing supplemental oxygen, and this was really reduced by 76%. And the effect persisted after adjusting for other confounders such as age, type of transplant, number of vaccines, etc. So they concluded that in SOT recipients with mild COVID, prior receipt of at least 3 doses of the mRNA vaccine dose and early sotrovimab therapy were associated with decreased risk of severe COVID-19. Okay, on to the next mAb. Tixagevimab, silgavimab, also known as Evusheld. This was the first monoclonal mAb approved for COVID-19 prevention, also known as pre-exposure prophylaxis. And it's longer acting than other approved mAbs, is given as an intramuscular injection, in fact, given as 2 separate sequential injections, one of Tixa, one of Silga. And the dose was recently increased to 600 milligrams due to decreased activity against circulating subvariants, and this is given every 6 months. Importantly, it was approved initially for pre-exposure prophylaxis based on the PREVENT trial, and later for treatment of mild COVID within 7 days of symptom onset based on TACL trial. I'm just going to show you some of the evidence in SOT. So the first study was conducted in France early during Omicron, and included only kidney transplant recipients for 30 in total that were low or non-responders to at least 3 doses of the COVID-19 vaccines, and the majority of these patients, so 333, received a mAb. And in terms of effectiveness, they found a decreased probability of hospitalization, and this was really reduced by 95%. They didn't see any major adverse events. The second study was conducted during the same period, but extended until April 2022, was conducted in the USA, mostly in kidney and lung transplant recipients. Most patients had received at least 1 vaccine, and half received the mAb, and the other half were vaccine-matched controls. And they found a decreased rate of COVID-19 from 14% in the control group to 5% in the mAb group. And in a subgroup analysis, the kidneys and lungs had significant reduced COVID-19 rates, but it's important to mention that those that had prior COVID, this effectiveness didn't hold. So they didn't seem to be a significant protection in that case. And they documented 2 cardiovascular events in the mAb group. It's also important to mention that there was a warning from the major clinical trials that assessed Tixa Silga that noted an increased rate of cardiovascular events in those with underlying cardiovascular risk factors and or cardiovascular disease. And as you can see, they just did a meta-analysis, including all major trials, and saw that an odds ratio of 1.9 for cardiovascular events. And then we started seeing reduction in susceptibility with BA.4 and BA.5. I'm just listing here some of the reports with BQ 1.1, XBB, which is increasing worldwide. And as of January 10, 2023, the NIH states that it's unlikely to be effective at preventing COVID-19 in the vast majority of individuals. And so why do mAbs stop working? Because the virus that causes COVID-19 is constantly changing, mutating over time to adapt and escape our immune system to continue to infect more people and persist, because otherwise the virus would disappear if it couldn't infect humans. And with increased use of a specific mAb, resistance is really expected. And Omicron in particular was characterized by significant immune evasion, not only to our own antibodies that we produce, but also to the mAbs that are marketed. So the most recently spreading BA.4 and BA.5, in fact, showed the highest levels of mAb evasion to date. But it's not all doom and gloom. So I'm going to tell you a bit of what's in the pipeline. So there's a next generation long-acting antibody combination, ADZ5156, called the Supernova trial, which has broad activity against multiple variants, including Omicron lineages. And it's including 3,200 immunocompromised hosts, both adults and adolescents. So looking forward to that data. There's also an oral remdesivir that was developed, and a trial comparing Paxlovid with remdesivir was actually just published. Although there were some issues with the outcomes that they chose, the trial suggested it could be non-inferior. And COVID-19 convalescent plasma, which has been around since early in the pandemic, and it's basically obtained from patients who recovered from COVID-19. It's potentially more efficacious than mAbs because it's more stable over time with emerging SARS-CoV-2 variants, as it's heterogeneous and has a broad spectrum of neutralizing antibodies. And recently, a systematic review and meta-analysis showed mortality benefit for immunocompromised patients with COVID-19. And there are ongoing clinical trials in immunocompromised hosts, which we'll be looking out for. And this is all for me now. I'll hand it over to Dr. Burton.
Thank you so much, Dr. Belga. Can everybody hear me?
Yes.
Yes. Okay, excellent. So we're going to switch gears a little bit now and talk a bit about a pediatric perspective on COVID therapeutics. We're going to touch on why do we need pediatric specific studies for COVID therapeutics? What are some of the barriers to doing these studies? What early therapeutic options are available for children, and what is the evolving evidence and some of the knowledge gaps there? And then why are some therapeutics only available to children of certain ages? Next slide. Next slide, please.
I'm trying to advance it. Sorry, Catherine.
Oh.
I'm going to stop sharing and share back again, see if it fixes the problem.
Okay.
I can take over, Sarah, if you want.
Sure, that would be great. That's probably better.
Perfect. Oh, sorry. Can you pull back? Thank you. Just so quickly, my disclosures, I'm very lucky to have some grant funding from some incredible agencies. Oh. Okay, next slide. So, thankfully, most children with COVID-19 have mild symptoms and full recovery, but more severe disease can occur. Children with solid organ transplants, thankfully, have also generally done quite well with COVID infection, and children with solid organ transplants are not clearly at an increased risk of more severe COVID-19 disease compared with children who are not on immunosuppressive medications. However, pediatric SOT recipients with COVID-19 do still appear to be hospitalized more frequently than children without any underlying health conditions. Now, it's not clear whether this truly does reflect that they may have more severe disease, or whether there's a tendency to admit patients to hospital when we're concerned that they may have more serious outcomes, which would have been especially common earlier on during the pandemic, before we really had much experience at all with COVID in our pediatric solid organ transplant recipients. Next slide. So can we actually predict which children are more likely to get more serious COVID-19? Because this is, of course, a very important question when we're talking about potential COVID therapeutics. Unfortunately, we can't really predict this very well. Different pediatric studies have found some differences in associations between underlying conditions and the risk of more severe COVID-19 disease. And I've highlighted here some of the conditions that have been identified in multiple studies, including children that have chronic neurologic conditions, Down syndrome, chronic lung disease, obesity, heart disease, diabetes, and then certainly something that comes up is when children have multiple underlying chronic medical conditions. Next slide. The other thing, of course, to consider with our pediatric solid organ transplant population is that children that are on immunosuppressant medications may not have as robust a response to the COVID-19 vaccines compared with children who are not immune compromised. They do, however, based on the current evidence, appear to have more robust responses to vaccine compared with adult solid organ transplant recipients. And there are several studies of COVID-19 vaccines in pediatric solid organ transplant recipients going on with a goal of identifying groups of pediatric SOT recipients in whom vaccine response may not be as strong and may be more at risk of more severe COVID-19 disease. Next slide. Unfortunately, we have very limited data regarding COVID-19 therapeutics in children, especially pediatric SOT recipients. So why is that? Well, there are a number of reasons, and I'm certainly not going to cover all of those reasons here, but pediatric research can be challenging. Incredibly important, but challenging. It can be challenging to recruit patients. It can be challenging to retain children for research, and it can be especially difficult to perform studies in children when the risks really are difficult to quantify and when research requires uncomfortable procedures like getting blood work done on a fairly regular basis. Another challenge of pediatric research in general is that multiple studies are often needed in different age groups of children because there are significant differences in different age groups of children in terms of how a drug may work for that child. Another thing that really makes COVID-19 research and therapeutics challenging in children is that generally to see an effect of a therapeutic, to see that something actually works, we usually like to study it in a population that has a high risk of having these outcomes or the more severe, like the outcome of more severe COVID-19 disease. And thankfully, the risk of severe COVID-19 disease is very low in children. So in order to be able to show that a therapeutic actually works, you would need really huge numbers of children to be studied to be able to demonstrate that effect. So that's a challenge in children in COVID-19 research in general. And of course, that becomes even more challenging when we're talking about specific groups of children like pediatric solid organ transplant recipients. Next slide. So why do we even need pediatric specific studies? Well, children are not little adults. People have probably heard this before, but they really aren't, and they really aren't when it comes to talking about therapeutics. So there are major differences in the way that the body handles the drugs in infants and especially younger children compared with adults. So the first thing we talk about is something called pharmacokinetics, and basically that refers to like the way that the body handles the drug. So how does the drug get into the body? How does it get absorbed? Where does it go? Where does it distribute in the body? Which can be very different when an infant has a very different body composition than, say, a 60-year-old. It also, there can be big differences in terms of how the body gets rid of the drug. So how does it break down the drug? How does it get it out of the system? There are also potential differences in the way that drugs act on the body in infants and children. And we talk about this is referred to as pharmacodynamics. So an example here is that, for instance, in certain ages of children, they may not actually have developed or have the receptors needed for particular drugs to work, or they may have less of those receptors or more of those receptors. And so that will have a significant impact on how the drug actually works in that child. The other really important thing to consider is safety of drugs in pediatric populations. We can't necessarily just extrapolate from adults. So there are some different potential adverse events that we may be concerned about, especially related to different developmental stages in children. So just one example is that there are certain drugs, for instance, that have effects on both growth, effects on bone growth, for instance, and that's certainly not something that we would want to not know about if we were using a drug in the pediatric population. Next slide. Okay. So I am going to use the trade names for these drugs to save myself, and also because I suspect that's what's most familiar to most of the people here today. So the first therapeutic that I'm going to talk about in pediatrics is Evusheld. So as Dr. Belga mentioned, it is Health Canada approved in children age 12 and over who weigh at least 40 kilograms for pre-exposure prophylaxis or prevention of COVID-19, as well as for treatment of mild to moderate COVID-19. So what is magical about this 12 years of age and 40 kilograms? Well, it's not magical. It's just kind of a benchmark. And really that's because this drug was approved for use in that population based on the adult data, and based on the knowledge that some of those things that we talked about before, like absorption, distribution, metabolism, and elimination of drugs is similar in adolescents as it is in adults, it was considered safe to use the same dose of Evusheld in adolescents as had been shown to be safe and effective in adults. Next slide. Okay, so what about studies of Evusheld in children? So there is an ongoing study of Evusheld in children from newborn to 17 years of age. And as Dr. Belga mentioned, Evusheld may not be effective in preventing a lot of COVID infection currently, but having the study of how the children's body handles the drug and how the drug acts on the body will facilitate more rapid study of future monoclonal antibody therapies for children. And also important to note that whereas the first studies of the original Evusheld did not include any pediatric patients, at least this next generation monoclonal antibody that's being studied is trying to include children over 12 years of age. So that's still a step in the right direction. Next slide. Okay. Moving on to remdesivir in pediatrics. So remdesivir, as Dr. Belga mentioned, is Health Canada approved for the treatment of COVID-19 pneumonia in hospitalized children age 12 and over above this magical 40 kilograms. It's not specifically approved in any pediatric age group for prevention of progression to severe COVID as it is in adults. And just to note, in the US, it is actually authorized for the use in children greater than 28 days for both of these indications. And we'll talk on the next slide a little bit about why that is. Next slide. So the approval of remdesivir in the United States was based partly on the preliminary results of a study called the Caravan study, which isn't published yet. But this was a study that was looking at the safety, the tolerability, and then these pharmacokinetics of treatment with remdesivir in pediatric patients, basically greater than a month old with mild, moderate, or severe COVID-19. These preliminary data included 53 children, and really what they could comment on was that the safety appeared to be similar to what was seen in adults, and they were able to get some information about appropriate dosing in these age groups. But this kind of trial really can't look at whether or not this drug works in such a small number of patients. So generally, the remdesivir appears to be well tolerated, but there are adverse events reported rarely. Sometimes it's difficult to know if these are all because of the drug or related to other things that are going on as well. But some of the things that we have seen reported are increase in the liver enzymes, which are reversible when the drug is stopped, some effects on the kidneys, and the drug is not generally recommended if there's really significant kidney dysfunction, sometimes a slowing of the heart rate when the drug is being administered. And as with every drug, essentially, there is the potential for allergic reaction. So with respect to remdesivir in children, really there is real need for further study to determine the efficacy in children, including children with solid organ transplant. But this medication is being used off-label, even in younger children in Canada, in consultation with people with expertise in pediatric infectious diseases. Next slide. Okay, very briefly to talk about Paxlovid in pediatrics. This is not authorized for children of any age in Canada, but it is currently being studied in children between 6 and 17 years of age. And again, this really is looking at the safety and how the body handles the drug and how the drug will work on the body. But very important to note that pediatric solid organ transplant recipients would not be included in this study because of the medications that they are on that would interact with the Paxlovid. So if this drug was even being considered for pediatric solid organ transplant recipients, it really would require careful study specifically in the pediatric SOT population, because there are clear potential risks due to the drug interactions. And as Dr. Belga had mentioned, some of these interactions may be avoided by changing the immune suppressant medications. But of course, this has risks as well. It can lead to toxicity or could lead to increased risks of reduction depending on how the drugs are changed. And we need to be particularly careful of this in children, I think, because the potential benefits of this drug are currently unknown in children. Next slide. Okay, so aside from these trials that are going on to try to find out how children's bodies process these drugs and how the drugs work on the body, we're starting to see some actual reports of how some of these COVID therapeutics have been used in children during the pandemic. And so here, this is a study from Seattle Children's Hospital, and they reviewed 94 pediatric patients for whom early therapy for either remdesivir, Paxlovid, or sotrovimab had been requested. And they, since the emergence of the Omicron variant, and then they describe basically the characteristics of which patients were requesting this and in which patients it was approved, what were the logistics, and kind of the short-term side effects, if any, associated with any of these. Now, even though this is a large children's hospital in the US, there were only 9 solid organ transplant patients that had, I guess, been looked at to receive potential early COVID therapeutics, and 7 of them received therapy. They don't describe why the other 2 did not qualify for treatment. And there are no specific outcomes for the pediatric solid organ transplants in general. But in general, the study did find that all of these therapeutics were well tolerated in the populations where they would use. Now, something else that I found particularly interesting about this study was that 66 of these pediatric patients actually had therapy approved, but only 47 of them ended up actually getting the therapy. And that was for a couple of reasons, most commonly because either by the time they got approved, their symptoms had gone. And so it was felt that they didn't really need the therapy. And the other reason was because of the family's declining treatment, mostly for remdesivir, because it is a significant undertaking to have to get 3 IV infusions on 3 separate days to get this medication. Next slide. So almost done here, and there will be certainly time for questions. So I have highlighted that certainly in pediatric COVID therapeutics, there are a lot of unknowns. So how do we even go about making decisions in the face of a lot of these unknowns? So the way that I think about it is that the first step is really trying to see if we can identify pediatric solid organ transplant recipients who may benefit most from these therapeutics. So potentially those with other underlying medical conditions that may further increase their risk of severe disease, or in patients who are much more highly immune suppressed that may not have a strong response to COVID-19 vaccines. I then would consider what we do know and what we don't know regarding the safety of the available therapeutics as it relates to each specific child. and then consider the potential benefits of the therapy, often having to extrapolate from adult data and take into consideration the current circulating COVID-19 variants. I also think about the feasibility of administration of whatever the medication might be, and of utmost importance is to communicate clearly with the patient and their family what is known and what is not known, and to consider patient and family preferences regarding potential treatment options. Next slide. I think actually we'll have to skip these in the interest of time, but I just did want to highlight that CDTRP is ultimately helping us to be able to solve some of these problems with this Treat COVID study. And the Treat COVID study will aim to address some of the important knowledge gaps related to COVID-19 therapeutics in adult and pediatric solid organ transplant and stem cell transplant recipients and their families. And these studies will look at short and long-term outcomes and assess safety considerations that are specific to transplant recipients, which are all critically important to enhancing the knowledge around COVID therapeutics in the solid organ transplant population. Next slide, and next slide again, actually. So I just want to leave with a few other important messages before we open it up to questions here. So the virus, SARS-CoV-2, changes and the evidence changes very quickly. So recommendations will change over time. Your transplant team will try to make the best decisions based on the available evidence at the time, but there's often not one clear, correct decision. Maintaining good communication with your transplant team is very important, especially when things are changing rapidly. And of course, advocating for ongoing research of COVID-19 therapeutics in adult and pediatric SOT recipients will benefit all of us. Thank you. We'll open it up to questions.
All right, thank you so much, both of you. Very, very interesting. So we are taking some questions. I see one person has put one in the chat. You can write it right into the chat. You can put your hand up if you want to ask it directly. You can also send me a direct message and I can ask it privately. Before we get to the one question in the chat, I just want to bring up something that came up in a discussion we were having with some of the others, specifically the pediatric families. And I think this applies to the adult population as well, because I've heard this from other people, in that the inconsistencies between the provinces. And since, as we all know, transplant is run provincially, as is all healthcare, it's not the same. So what someone is given in BC is not what someone in Ontario is given. And I think there's a lot of confusion about that, especially when we see the data coming in from the US and what they're doing there, or from around the world. How do we manage that? Because I think that is a problem, not just about therapeutics, but I think it's really come to light over COVID in general about the care of transplant recipients, the inconsistencies between the provinces.
Yeah, Elaine, I mean, that is a fantastic question. And unfortunately, I think a question that we probably are not in the best position to answer, because we, in a similar way to you, are working often within the constraints of the provincial systems, right? And that doesn't just apply to this, but I think you're right. I think that COVID really has highlighted that, right? So in terms of how to solve that problem, I don't think, I wish that I had a simple solution for that. I certainly don't have a simple solution for that. But I have to say that just the fact that it really has come to light, and that I think that the public and a lot of people, especially that are highly involved with the healthcare system, have become so much more aware of it during the COVID pandemic. I think that that does give us some power in, you know, being able to potentially bring that forward and maybe to make change in some ways and bring it to people's attention that this is a concern across Canada. I don't know if that, I know that doesn't answer your question, but I think that's kind of the best that I can do in terms of just like addressing it.
No, thank you. Thank you. I'm not expecting overnight changes, but you're right. It has brought this to light in a really harsh way. And Sarah, I don't know if you have any comments you want to make on that before we move to some of the other questions here.
No, I really don't. I think Catherine answered really well. It's hard. It's hard because Canada can be really compared to the United States in a lot of ways. It's very different with a publicly funded healthcare system, and then within the different provinces, the evidence is not always clear cut and certain that this is going to provide benefit. And when there's uncertainty, there's going to be different decisions across the provinces. So.
All right, thank you both. I mean, and I also love to hear from any of the people attending today, have you found inconsistencies? You go to your care team and they say, oh, we don't do that here. I think that's also, again, opening up the door to that conversation. But let's go through some of these questions. I'll start in chronological order, so we may not have time to get to them all. I'm not sure if our two experts can stay on for a little bit longer. First of all, Eric would like to know, would you comment about the potential role of oral remdesivir in transplant populations with mild to moderate COVID?
But I guess I can answer that because I did allude to the trial, which was actually, I think, published 2 days ago or 1 day ago, just right after I had my slides finalized. Just to tell you, it's really hard to keep up with all of this evidence. So first of all, we don't have oral remdesivir approved yet. This was just based on a clinical trial comparing it to Paxlovid. And I'm just looking at the paper right now saying that it was basically non-inferior in terms of time to sustain clinical recovery. I guess it's a bit different from the primary endpoint that was originally determined on the Paxlovid trial. But just to say, yes, I mean, if we do have oral remdesivir available, I guess it's going to also depend on cost, but would definitely be better than IV and having to come 3 days in a row. So yes, I would love to have that as an option, but unfortunately it's not yet close to being approved or marketed from what I understand.
All right, thank you. I think this next question, Catherine's probably best answered by you. How often are these therapeutics being used in eligible transplant children in Canada right now? I mean, you said some of it, some rare sort of off-label considerations. I mean, are we talking like a handful? Are we talking, a dozen? The population is small as it is, so.
Yeah, so I mean, I unfortunately really can only speak to our center, I guess, and then kind of the casual comments that I have heard from others, because we don't have at this time actual, evidence. We don't actually know exactly what's happening, which is why this study, the COVID therapeutic study that CDTRP is facilitating, is going to be so important, because I think that it's going to give us some information even on, what is even happening, like what is the lay of the land when it comes to that, right? So at our institution, I can say that it has been, relatively small numbers, and it has changed quite significantly over the pandemic in terms of what was available and what the logistics were with administering those kinds of things and ages of children and that kind of thing. But I would say, yeah, generally small numbers of children in the solid organ transplant population that have been receiving these therapies. We have tried to identify children that we thought might have been at higher risk of more severe COVID, especially early on in the pandemic when we really didn't have any idea what the implications would be. I would say that we were perhaps a little bit more aggressive in terms of using some of those early therapies. And then over the course of the pandemic, I would say that we've probably overall become a little bit less aggressive with that, because we have seen that on the whole, the majority of our transplant patients, are vaccinated, and when they do get COVID, have done relatively well. Certainly recently, we have treated some children with remdesivir, which has required generally bringing them into hospital, and those are for specific situations where there were other things that we were concerned about, other potential risk factors for severe disease. I don't know if that is helpful at all.
I think that's great. Thank you. Okay, we have a few more questions to get through. So being mindful of time, are you two okay to stay on for a few more minutes, or do you have a hard out at 1? You're okay, perfect. Okay, so let's go through these. Here's a question from Ernie. Considering the changing effectiveness of Evusheld, what are your recommendations for adults who will be traveling and therefore have increased exposure to newer variants?
I guess it depends on whether you're asking for my recommendation versus what the public health recommendations are in the province you're in, which is going to vary a lot. And also you're going to hear different opinions from different people based, I guess, on, the evidence that's out there and sort of like how you balance risks and benefits. But I would say the most important thing is obviously making sure you have all your vaccines that you're eligible to. I would say that's like the foremost important prevention aspect. And then I would say, obviously, the non-pharmacological measures, including obviously wearing a mask, it's very important. Now, how much is Evusheld going to offer as extra layer for protection? We don't really know. So in my mind, at this point, I probably wouldn't recommend it. Also, because it can offer that false sense of security because you have it thinking it's going to protect you, but we really don't know how much it's going to protect you. And if someone already, it also is going to depend on a lot of other factors, right? What type of transplant did you have? How old are you? Have you had COVID? What kind of, have you had rejection recently? Did you receive rejection? So there's so many other aspects that you need to take into account. It's hard to answer that question. Sorry, maybe not the answer you were hoping for.
Thank you for that. Okay, another question, Eloise. Is there any evidence of resistance, increasing resistance to Evusheld? I think that's what it was. Hang on, it just popped down.
To remdesivir.
Oh, remdesivir, sorry, not Evusheld. Remdesivir, increasing resistance, emerging resistance.
I mean, it's a great question. I think there has been, some reports of it. I don't think there has been evidence of emerging resistance, but that's possible. Though the way these drugs like Paxlovid and remdesivir work versus monoclonals are different. And so because of the recent variants being more immune having the ability to escape the immune system, with that leading to development of resistance much faster versus development of resistance with the other antivirals. I mean, we certainly have seen that with other respiratory viruses, including influenza. So it's quite possible. And I think what I tell you now may not be true in a few months, but we haven't seen yet emerging resistance that would be of concern at this moment.
So I think my question kind of feeds into that. Sorry, my question's the next one down. Is that okay?
Go for it. Yep, go for it.
So 11 days ago, my daughter did get the 3 doses of remdesivir. And so I'm just wondering, public health called us after, not because she had remdesivir, just because she had a PCR, right? So they called. And they said that she can basically, because of her immune system, basically get COVID right away again. We have no way of knowing, right, if she would get any immunity for the like everybody else. We kind of would be under an umbrella of immunity, hopefully for a while, but keep her home for 10 days because she could get COVID right away again. So if she were to get COVID, would there be evidence to support using remdesivir again, or is there any limit to the use of remdesivir? Is there a 3-month recommendation of using it in between? Do you know what I'm trying to ask here? Sorry, that's why I didn't type it out, because I'm not super clear.
That's a fantastic question, and of course I don't know the specifics of the situation.
No, I didn't want to go too personal. I didn't want to
exactly
monopolize your time.
Do I want to? But it's different. No, I don't think, were there to be an indication to use remdesivir again, if it was felt that there would be an indication, then I don't think that there would be an issue with using remdesivir again. So it's not something like some of these monoclonals that has a very, very long half-life and that kind of thing. So I don't think that there would be an issue with using remdesivir again if that was something that was felt to be in her best interests, basically. Also, I will say that, public health and when they were talking to you about the fact that she could get, COVID immediately again, I mean, of course, as we talk about, children with solid organ transplants, it can vary significantly, kind of the state of their immune system and their risk for different infections, absolutely. But I would still say that, overall, the evidence would suggest that children that have had COVID do mount a response to COVID.
I would hope so. It was very strange. There was 1 positive case in her class, 1. And within 48 hours, she was positive. No one else in her class has had it or had any symptoms. That's the only exposure she's had in 3 years, and she caught it like that.
Yeah. So, I mean,
it's hard to know, right?
Yeah. I think that, having had COVID does generally still patients that have had organ transplant do mount some response to it.
Okay.
Is that perfect protection? No, it's not perfect protection, but I think it's also not nothing.
No, and she didn't sound like she caught it back from her brother. It's been in our house now, right? Like they didn't keep passing it back and forth. Okay, thank you so much.
Thank you, Sarah. Do you have anything to add to that question about how many times you could take remdesivir?
Yeah, I can answer that because I've been asked that question multiple times. I think, I would say I wouldn't worry about getting COVID again in such short period. It's more likely some very immunocompromised patients will shed COVID for a long time. But we do know that hybrid immunity, in fact, both vaccine and infection do lead to better immune response and perhaps more protection. So I think that's important to take into account. In terms of repeat remdesivir, if it's like someone gets remdesivir and then a month later still has a positive PCR, definitely I would not recommend it because first of all, it's PCRs can persist for a long time without the virus replicating. The other question is for like those people that have chronic COVID and you can't get rid of it with a first infusion and then months later they still have COVID. I mean, we don't really know because there's not enough evidence to know what actually works because it's all based on case reports, case series. And so it'd be great to actually have had a clinical trial for immunocompromised patients, particularly those that have rituximab and other therapies that basically just deplete the B cells that are very important to control COVID. But unfortunately, we don't know. I would not usually recommend that, but it's on a case-by-case basis.
All right, thank you. We have 3 more questions. So this one is actually about when to get the bivalent. It came in directly to me, just so you guys won't be seeing it in your chat. The bivalent COVID vaccine, is it recommended? I could say that it is recommended, of course, for solid organ transplant recipients, no matter where you are in Canada. But this question specifically is, this person has had Moderna, has had Evusheld, and then got COVID and was given remdesivir. So I guess maybe a good question there is, do you delay the vaccinations after receiving one of these monoclonal treatments, or do you sort of go with that? Like, I know there's sort of the varying like 3 to 6 months post-infection type recommendations. So any recommendations or comments about vaccines after receiving various treatments?
I would say that after having infection, I would recommend delaying the vaccine because I think it may be actually counterproductive to get the vaccine while someone is convalescing or recovering from COVID. So yeah, in that regard, it may change, but usually I think the recommendations are to delay it by at least 3 months, as we learned that giving it too early after having COVID may not actually help the immune system in any way. So that is that. I'm not sure if I answer your question.
Well, and then what about if you've been receiving treatment? If you received a monoclonal treatment, does that delay, should that delay your vaccine? And also too, I guess the second part of the question is, I assume that under all circumstances, you should get the bivalent now, regardless of whether you've had monoclonal treatment, had COVID or whatever. Whenever you're due for your shot, everyone should be getting the bivalent.
Yeah, I mean, I definitely would recommend the bivalent with the most updated variants. With regards to, I guess I can't actually remember, but there's like some recommendations of the Evusheld and then the next vaccine when I think there's like an interval that you should wait. But it's not a very long interval, if I remember correctly.
2 weeks.
It's 2 weeks.
Okay.
Yeah.
Okay.
But
if you've had COVID, what you're saying, Sarah, is you should be waiting a minimum of 3 months.
Oh yeah, no, I would. Exactly. I think this is a bit of a very unique scenario where there's a monoclonal, there's COVID. I think there's too many things at play. But I would say if there has been recent COVID, yes, I would definitely delay the vaccine by at least 3 months. But yes, and there's like a certain recommendation to space it out from the vaccine, which is 2 weeks. Thank you, Dr. Burton. And I would say, yeah, there's like the theoretical concern that if you have a monoclonal, that could decrease your own immune system response. But I don't know that we know enough about it.
Okay. All right. Thank you. Is there anything you wanted to add, Catherine? No, you're good. No. Okay. All right, we got a couple more questions here. What degree of kidney damage would you have before you would be recommended against taking it? So, you mentioned one of the things, sort of the guidelines was if you have kidney issues. So how bad does it have to be, or is there some threshold or some kind of marker?
If this is regarding remdesivir, Paxlovid, is that
Evusheld, sorry, Evusheld.
or Evusheld?
I had mentioned with respect to remdesivir
okay.
that there are considerations just with respect to renal dysfunction. I am not aware of considerations for renal dysfunction with Evusheld, but I'm probably not the best one to ask about that. I don't know, Sarah, whether you're aware of anything with Evusheld. I'm not
aware of any concerns with renal dysfunction and monoclonal antibodies, only with remdesivir and Paxlovid, as far as I'm aware.
Okay. All right. And then our last question today, is there any correlation with the therapies for SOT patients and long COVID?
Yeah, it's a tough question. I think we need more research to better answer that question. I think vaccines, I think there has been some evidence in non-transplant patients that vaccines could decrease the rates of long COVID. I'm not aware of any data, but like I said, it's completely impossible to stay up to date with all the COVID studies. So there could be a study looking at that, but I don't think I would expect a significant impact. I think the most of the data suggests it decreases the chances of progressing to severe disease, but I have not seen any data showing any impact on long COVID.
Okay, so that is all the questions we have in the chat. Thank you both for staying on late to answer. I'm going to give everyone one final opportunity to raise your hand or jump in with any questions. We did have a couple interesting comments from Lori and Sherry about, of course, the problem of the interprovincial confusion. Apparently, Sherry says it happens in the US too. So it's not just a Canadian problem, it's an everywhere problem, it sounds like. So it doesn't look like there are any other questions. So I'm going to close today's really engaging session. I want to say thank you to everyone for participating and for all your questions and your comments throughout the presentation. Thank you so much, Drs. Belga and Burton, on behalf of the CDTRP for presenting. If you do have additional questions, comments, or if you have suggested topics and speakers for future events, please contact Erica Cathcroft. I think we can put her email in the chat for anyone who wants to do that. So thank you so much, everyone. And I hope you enjoy your day. Happy Wednesday.